If a patient's tumour is small, pathologists are naturally concerned that there may not be enough tissue for both whole genome sequencing and diagnosis. There are some innovative ways to avoid impairing the diagnostic material, and here's Dr. Lisa Browning with some ideas. She's using renal material.
As part of the development of the renal tumour sampling protocols, we've tried to look at a variety of methods of sampling the renal tumours so that you can increase the number of tumours that you are actually getting samples from, even the small ones and the necrotic ones, etc. What happens with all of our samples, not just the renal tumours but across the board, is that they are collected from theatres by a member of the biobank team. So when the biobank team actually contact theatre, they're given an estimated time that the specimen will be ready, and they go across to the operating theatres, and having checked all of the consent and everything for that patient, for that sample is correct and in place, and they're then able to collect that specimen. But the important thing is it's not put into formalin, it's kept formalin free and put straight into a plastic bag onto ice into a bucket, and then it's transported across to our laboratory here for us to then sample the tissue fresh. After macroscopically examining the partial nephrectomy specimen, on the nephric margin I could see that there was an area there that I could just about see the tumour, so I was concerned as to whether or not that tumour was either close to or involving that surgical margin. So in the first instance, having recognised that, I was able to ink that differentially. In this case I chose the colour blue. And then I inked over that whole area in black, which is just the colours that I tend to use because they show up very well on the H&E sections. And then I inked the capsular surface or the perinephric margin in a different colour just to differentiate between the two after examining the specimen. Part of the macroscopic examination is for assessment in partial nephrectomies, particularly of the surgical margin, and another way that you can document that is by taking macroscopic photograph or image as a permanent record of that margin and of the capsular margin as well, and that's something that we do fairly regularly and would particularly do if we were worried about tumour being present at that surgical margin, just as a permanent record prior to inking the specimen. We've done our macroscopic examination of the specimen. We've also inked the relevant surgical margins. So the next stage in the process is actually to open the specimen, so using a fresh, clean, sharp blade. And if you're worried at this stage, if you're worried about any aspect of that surgical nephric resection margin, it's important to avoid that area when you're taking your fresh slice into the specimen. So you just slice it into two pieces, be it into half or a third, 2/3, to expose the cut surface of the tumour. And then after that you can choose how you're going to sample your tumour. If you're concerned about the nephric resection margin, because you can see tumours definitely at that margin, but you still have a tumour that's big enough for you to be able to take a sample for fresh freezing, then you could alternatively avoid cutting into the nephric resection margin by actually taking your slice parallel to that nephric margin. So that slice would again expose the cut surface of the tumour, but would have avoided the nephric resection margin. So that's an alternative way of doing it. After the specimen's been cut open and the cut surface of the tumour is exposed, then there's a variety of different ways in which you can sample the tumour depending upon what the cut surface looks like, whether you've got large areas of necrosis, whether there's large areas of cystic change, and also depending upon the size of the tumour. So the macroscopic appearance of the tumour is going to influence the way in which you choose to sample it. The methods that can be used include the fine needle aspiration, a 5mm punch biopsy or a 2mm punch biopsy, and with any of those techniques, for example the 2mm punch biopsy, provided the tumour is big enough, you're at liberty to take several of those punches, and then that tissue can be collated in order to provide sufficient DNA for extracting. The FNA process is useful in two situations. So it would allow you to sample a tumour from a specimen that perhaps you didn't want to open, possibly because you didn't want to compromise the surgical margins. It may also be useful if you've got a sample that you have opened but the tumour is actually very small. The process actually involves you taking a fine needle, so a small needle. At the moment we're using a 22 gauge needle onto the end of a 10mm syringe, and then FNAing the specimen, so you hold it steady with one hand and then just insert the needle into the tumour with the other hand, avoiding your hands at all costs, and actually just applying some suction onto the syringe and moving the needle and the syringe into and out of the tumour, and sucks up into the barrel of the needle some of the tumour cells, which can then be washed into either PBS or lysate. And at the moment we're putting our samples into both solutions, as we're in a process of establishing which is better in terms of preserving the specimen.
Actually, the renal sample used here is not particularly small, but you can see how this technique will work well for smaller tumours.
You'll notice that there's very little in terms of evidence of where that needle's actually been, so it's good for very small tumours. So far we've used the FNA technique on 5 renal tumours, and we've used it at the moment alongside our standard technique to make sure we weren't compromising the opportunity of getting a fresh tissue sample. But actually it appears that FNA is a very good technique for obtaining sufficient DNA for future extraction of the whole genome sequence. So the results that we've had so far, we've achieved a DNA content or quantity of DNA of at least 2 micrograms, so in the range of 2 to 5.9 micrograms across the 5 samples, and it appears to be that the samples put into lysate have a slightly higher yield than the samples put into the PBS. Renal tumours sometimes can be quite cystic, in which case if you put the needle in blindly, so without opening the specimen, you might draw out a lot of the fluid content from the centre of the cyst rather than having a solid tumour. So you could potentially avoid that happening by checking the radiology beforehand. Another example might be if the tumour is quite necrotic, because again you might be pulling out a lot of necrotic tumour cells which aren't going to be useful for extracting DNA from. And the issue about the FNA sample is that it's difficult to assess tumour content from that sample, so there's not a great opportunity for you to actually visualise those tumour cells in comparison with the fresh tissue punches where you can actually see the tumour, for example, on a frozen section or on a mirrored block. The FNA samples that you take into the preservative solution, be it PBS or lysate, can then either be put directly into liquid nitrogen, so fresh frozen essentially, or it can be placed into the fridge. Depending upon the size of your tumour, it's often possible with renal tumours particularly, because they do tend to be fairly large, to take a 5mm punch biopsy from a solid area of tumour, avoiding areas of necrosis, avoiding areas of cystic change or areas that look scarred in which you're not going to be picking up any tumour cells within your 5mm punch. And you also want to avoid any areas which are important for staging of the tumour, so for example avoiding the area of the renal sinus if that's present in the specimen, and avoiding the capsule of the tumour and the perinephric fat. Additionally, ideally you want to take your sample well away from the nephric resection margin so that you're not compromising that for diagnostic purposes for the patient. Then we use a 5mm skin punch biopsy, which is very sharp on the end and is easily able to be pushed into the solid area of the tumour and a 5mm core taken out. That core can be snap frozen in liquid nitrogen. To determine where that core has been taken, we ink that differentially. So I usually take 2 punch biopsies just to make sure that I've managed to get tumour that's got enough tumour cell content for the purposes of the project. So I would normally ink the fresh frozen core 1 hole in black and that for the second core in blue, but that's just the way that I choose to do it so I can remember it. If If you're worried about compromising margins or the capsular surface, then one thing you can do while the tissue is in its fresh state is actually to take a slice parallel to the original cut surface, a 4mm slice, which is actually block thickness, and then you can actually lay that down flat on the cutting board and take your 5mm punch biopsy from that, and then embed that slice, which might include a margin, straight into a cassette for processing as per routine, so back into formalin and into a paraffin embedded tissue block. You can use smaller gauges of punch, so for example a 2mm punch biopsy, which allows you to sample several areas and then to collate that amount of tissue, which will provide you with a sample that's roughly equivalent to what you would have obtained with a single 5mm punch. And the technique's essentially the same, so you just select a solid area of tumour and take the 2mm punch out of that, and that's snap frozen, and then make sure that you've inked the holes from which the tumour sample's actually been taken so that those are identifiable, and the block is then just processed as per routine. The main issue that we've come across is that the 2mm punch, the actual hole from which the tissue actually sits when it's taken out of the specimen, is obviously narrow, and sometimes the tissue can get stuck. So one way of getting the tissue out is to use a fresh scalpel, so a sterile scalpel, to actually just gently lift the tissue sample out from the end of the punch, and then you can put it into the vial for fresh freezing. To take a punch sample, the whole thing from start to finish would take about 10 minutes. After you've taken your fresh tissue sample, one of the important things for the purpose of the project is to be able to assess the tumour content of that tissue sample. And one of the ways in which you can do that without relying upon taking a frozen section from that core is to actually use a mirror block technique. So you would have your specimen, the cut surface basically exposed, so you've got two cut surfaces. You've taken your punch from one of those cut surfaces, and then if you imagine that the other cut surface is the mirror image of the side from which the punch has been taken, you could then indent the area from which the punch has been taken on the unsampled surface, and then take a fresh tissue block from around that to include that mirror area from the core on the other side, and that would be your mirror block. Mirror slicing as part of the tumour sampling protocol usually takes a couple of minutes at the most.